2 p.m., so you could go ahead to start. You're muted, Greg.
Thank you very much. So good afternoon, everyone, and happy Friday to everyone. Welcome to our Mrftt HIV STI Echo session. I am Dr. Gravely Boyce. Next to me, who's our Echo newbie, is Mr. Akeem Williams. He's our adherence counselor at Mrftt, and we welcome him to our community of learners and to our Echo family. And we want to give a special welcome to Dr. Chase Cannon from Assistant Professor in Infectious Diseases and Allergy at the University of Washington. He will be speaking to us about what's new in PrEP, pre-exposure prophylaxis, and PEP, post-exposure prophylaxis. And no matter how many times we go over the guidelines, we always be confronted by a case that kind of scratch your head and not quite sure what to do. So it's really, really great to have sort of someone out of his experience and skill to educate us and educate us all about what's new in PrEP and PEP. So it's kind of, the floor is yours.
Okay, thank you very much. Are we seeing the right version of the PowerPoint? That look okay to you?
Yep, looks good.
Great. So thank you for the invitation. Good to join. I know that we're many kilometers away from each other, but we're all working toward the same mission with our patients for HIV prevention. So I'm glad that we have this time to talk. Before we get started, I did mention just briefly before we started recording that I'm interested to hear from all of you if there are particular aspects of HIV prevention related to PrEP or PEP that you are most interested in, or questions that you might have, because there is a lot of content here, and I will sort of move past some of the material maybe that isn't as pertinent. You'll have the slides and you can look at that later, but maybe if people are able and want to unmute and just say, what they are interested to hear, or put it in the chat, that would be useful for me moving through. So maybe I'll give it a few seconds for that if anybody has thoughts. I did hear one person say before that they're interested in some of the challenges, basically, not sure what to do on certain things, and then long-acting injectables was a point of interest. Anything else? Yep. Yeah, in the chat. Okay. Well, people are shy. That's all right. So we'll move through, and then feel free to ask any questions or stop me along the way. So this is our disclosure here. And the objectives that I have today are to talk about certain areas of clinical uncertainty for HIV PrEP care and considerations for monitoring. So specifically around the idea of needing a viral load to monitor for PrEP, and then understanding some evidence about alternative PrEP regimens, and then what's coming down the pipeline for HIV prevention. So this is the general overview. I think it is tough to think about statistics across different countries. And so a lot of the data that, we have from WHO and from CDC in the US, unfortunately, I don't think includes much information on your country. So that was hard for me to do. But I think generally speaking, some of these principles will apply across the board. So we'll talk about a few of those. So let's get started. So knowing what we do about HIV diagnoses, at least here in the United States, things seem to be improving in the sense that cases are decreasing slowly over time. So from 2017 down to 2021, we have seen a slight decrease, which is good. There was a little bit of a dip because of the pandemic, and a lot of that had to do with people not having access to testing. And people think perhaps the little increase up was due to delayed diagnoses being made in the setting of the pandemic. But at least here in the United States, we have a sort of national initiative called Ending the HIV Epidemic that is very aspirational, looking to decrease the number of new diagnoses by 75% in 2025 and by 90% in 2030. And so right now we're at about 36,000 per year new HIV diagnoses, and to get down to 3,000 per year is going to be a major task. And so the way that we propose to do that, and these things I think will all make sense to you, is we want to diagnose people with HIV as soon as possible, treat people who have HIV rapidly and effectively, because that is the way that we prevent forward transmissions, preventing new transmissions by using PrEP, and then responding quickly to outbreaks whenever those happen. So let's talk a little bit about PrEP. I think maybe all of you know what this is, but just so everyone's on the same page, in case some may not be as familiar as others, pre-exposure prophylaxis is a prevention strategy, a biomedical prevention strategy, where a person takes antiretroviral medications to prevent acquiring HIV. So question comes up, who is a candidate for PrEP? Really, any person who desires PrEP should be offered it. And I heard that, we're still sort of working to get a PrEP program up in your country. And so as you're thinking about who you might roll this out to, really anyone who desires it should be offered. And that could include all sexually active adults and adolescents. So we have evidence that this works for people, all the way down to, age 13, 14, if that's what, the people that you're seeing. But at least they should be informed about PrEP, and if they are seeking it, to be offered PrEP. So there are 3 medications that are sort of approved in the United States, and I think around the world are the ones most commonly being used. The dapivirine vaginal ring is an option outside of the United States in some countries. It is not moving forward with approval here, but the options that you see 1 through 3 are others that are available. I would say number 1, oral tenofovir disoproxil fumarate emtricitabine, or FTDF is how I'll abbreviate it here, also brand named as Truvada. That was the first option, and that's the one that I think is the most common and the one that's most readily available for people. There's another version called FTAF or Descovy that was approved after and has some limitations that we'll talk about. And then the newest agent sort of on the block is injectable cabotegravir, which can be given every 1 or 2 months, and that was approved a couple of years later. So we know that oral PrEP is very highly effective, but it really depends on adherence. And so you're not meant to necessarily look at every single line on this slide, but I just wanted to draw your attention to this bottom sort of triangle here, where it says overall and subtotal. So essentially, if people are taking the PrEP, it favors it being active for HIV prevention, and that is across many RCTs, so randomized trials. If you look at the table on the right side, the effectiveness is really dependent on how much people take it. So in these different populations, men who have sex with men, heterosexual people, and then people who inject drugs, if the adherence is less than 80%, the effectiveness really drops by about half. So anywhere from 90% in those trials to like 45% if people aren't taking it effectively. And we didn't have as much data early on, and I think really until the last few years for women. And there's a lot of misconceptions out there that oral PrEP is only for men or transgender people, and that is not the case. It is absolutely effective and should be offered to women who are interested. And so there's new data that was just published actually about a month ago that is looking now at whether women need to have as high adherence as we had thought previously. And I think the answer is no. So now I think across the board, as long as people are taking what we consider to be, consistent, moderate doses. So what that equates to in terms of numbers is at least 4 doses per week, that the HIV incidence in those people is quite low. So that's sort of depicted in this graph on the right side. So people who have low adherence tend to have a higher HIV incidence rate, and then people who are taking at least 4 tablets a week have a much lower incidence than 1 per 100 person years. So it doesn't have to be perfect. 4 times a week is probably enough. We don't necessarily tell people that that's what they should do, but in case you have someone comes to you and that's what their adherence is, they can feel confident that they have pretty high protection. So the question about long-acting cabotegravir, which is an injection, was studied in 2 different trials, HPTN 083 and 084, and was found to be superior to oral PrEP for HIV prevention. So the reduction in the first study that was in cisgender men and trans women was around 65%. And then in cisgender women, the study actually showed that it was higher in the cabotegravir arm in 88%. And really, we think a lot of this has to do with adherence. So people who don't want to take a pill every day are not going to take a pill every day. And so if they have the option to get an injection, that's going to work better for their life, and they're more likely to adhere to that. And so that should be an option. However, we know that access to long-acting and injectable cabotegravir is challenging across the world. So not only in the United States, but many countries. So lots of places in sub-Saharan Africa are really struggling because the studies were done there, but then they don't have good access to the product for people. So that's logistically sort of a challenge, and I think a big deal whenever we're doing studies. So I will skip some of these data slides. We can talk about them. They're sort of US specific, but we basically know that PrEP is not being offered to everyone equally. So at least here in the United States, white men who have sex with men are the people who are offered PrEP most often, and then women and other populations sort of get left behind. So as you're thinking about rolling out PrEP, equity is always an important consideration, that you want to make sure that you're not sort of selectively offering to people who might be at risk as much as you can. And I say that being in a place where that does not happen. So I think that's a goal that we all should have. So the way that I thought about framing this was when different clinical considerations come up when you have a patient right in front of you, I thought that I might sort of make a case, and then we can sort of work through how you might sort of approach different issues that come up in that person's clinical care. So this is a person who comes to clinics to start PrEP. They have reported to you that they engage in receptive and insertive anal sex and have had 3 male partners in the past month. So the first question that you may ask yourself is, which PrEP medication is indicated for this person? So this next table is busy, but I think I hope this could be a resource for you. And I've pulled this together from lots of different resources. So from CDC and the International Antiviral or AIDS Society, which is one of the other bodies that makes guidelines, and then WHO, I'll show you some of those later. But what we offer people depends on their gender and the type of sex that they have. So if you're talking about cisgender men, any of the options are available. For cisgender women, some of them can be available, but we have to use some caution when we're using the oral FTAF or Descovy, especially if people are considering using something not on a daily basis. And then for adolescents, as I said, 12, even down to 12 or 13 years old, the PrEP options, both oral and injectable, are available. And if you're thinking about PrEP in pregnancy, we can sort of discuss that, but oral FTDF is still a good option. The only caveats are that a person needs to be at least 35 kilograms in weight, because that's the way the studies were done. And then there are some kidney function considerations as well. So if we focus sort of on this middle column here for this particular person, these would be the options that I would offer to them if they were in front of me for care. So what are some of the comorbidities or other medical conditions that might impact our decision on PrEP? So I said renal function is one of them. So there are particular creatinine clearance cutoffs. So when someone's coming in for PrEP, you want to get kidney function labs so that you can know which of these options you can give. Importantly, the injectable version of PrEP, cabotegravir, does not have any impact on renal disease and doesn't have any particular cutoffs. So even if somebody is getting dialysis, they can still take that medication for PrEP. And then otherwise, there are some mild sort of reversible kidney and bone effects that can happen with oral FTDF or Truvada, and that is reversible if people stop it. It's super rare, but I think a lot of people get worried about that, and I try to counsel people that that's not as much of a big deal as people think. But otherwise, there aren't really any significant contraindications to using those. So lots of things to consider, but it is fairly straightforward once you get these few things down. So I don't know if people have heard about this idea of on-demand PrEP or what is called 211. So this is essentially a strategy where people may not want to take oral PrEP every single day. So say, for instance, they don't have sex very regularly. They have a partner who lives far away and they only see that partner on a weekend or something like that. They can take PrEP just around the time of sex. And so the way that's done is you take 2 pills between 2 and 24 hours before sex. And then you have the sex event, and then 1 pill you take 24 hours later, and then 1 pill 24 hours later. And doing that strategy basically will cover that sex act in terms of HIV prevention. And then they don't have to take any more pills outside of that. So it is for people who can anticipate sex, who are able to take the pills around the time of sex. So it may not be for everyone, but it is an option for some people. And there is some guidance on who can do this. So it is a little bit limited in terms of which body compartment is protected. And so WHO essentially says this can be recommended for sexual exposures for cisgender men. For transgender women, they say use caution if people are on injectable hormones, and not recommended otherwise for these categories that you see here, particularly people who inject drugs who may not have sexual risk, just because we don't have data. And an important thing to know as well, all of these options for PrEP is you want to know someone's hepatitis B status. So if they have active hepatitis B, which would be an S antigen that's positive when you get their labs, this is contraindicated because they need to be on a medication daily and be counseled that they shouldn't take it sort of on and off because there's risk of hepatitis B flare. So our patient says that they want to do daily PrEP. So what do we tell them in terms of adherence? So we talked about this a little bit, but we now have a lot of good data that shows that if a person takes at least 4 tablets per week, and it can be up to 7, then their protection is essentially 100%. If they take only 2 or 3 tablets a week, that drops down to about 87%. And if they take less than 2 tablets a week, it's 51%. So again, this is for people who are supposed to be taking it daily. If they don't hit that mark, their protection drops pretty significantly with the adherence. And we know that, not only is adherence important, but also persistence. So once people start on PrEP, we have to do everything we can to support them to remain adherent to it so they can stay on it and continue to have those benefits. And so there are studies that essentially show what this slide is telling you is that the HIV incidence is high in people who start PrEP and then they stop and then never restart, which I think makes sense to us. And then the incidence is a little lower in people who end up restarting later. But that middle group here, the people who stopped and did not restart, have the highest incidence of new HIV. So it is important to try to support people for their adherence and persistence as much as you can. So these are a few strategies that you can consider, telling people how they can work this into an existing routine that they have. So, take your pills every time you brush your teeth or whenever you wake up to make breakfast, take it then. There are some side effects that can occur, especially with the oral PrEP, what we call a startup syndrome. So people can have upset stomach, nausea, cramping. They can even have some diarrhea. Usually that goes away within the first 1 to 1.5 weeks of being on daily PrEP. And so we tell people that ahead of time so that they don't get really concerned and want to stop it thinking they're having an allergic reaction. So that's a kind of preemptive discussion to have. And then reinforcing, of course, the benefits compared to the relatively few and uncommon harms, talking about adherence, which we just discussed, being real with people and saying, we're all humans, we miss doses sometimes. I'm not perfect with medication that I have to take. And so if you're not, that's okay. But we, say that we aim to take it 7 days a week. But if you fall at 5, that's perfectly fine. And then other strategies that you see there could be helpful. People might want to use like a pill box or something else that helps them remember to take medications. Even with that, I think there are still a lot of barriers that could be both individual, social, and structural. And I think some of these may be the case for your country as well. I think a lot of places around the world where awareness and knowledge of PrEP for both patients or the people who would use it and then providers is low in a lot of places. And that often has to do with sort of cultural differences about sexual health and how we talk about sex and HIV prevention. Sometimes there's a mismatch in what people perceive their own HIV risk to be and what we as providers think it is. lack of access to a provider who is understanding and won't be judgmental if somebody says that they have sex with a person of the same gender as them. And then just generally speaking, there's a lot of stigma related to HIV, not only people living with HIV, but people who are seeking PrEP care. So all of these things can keep people from coming back and decrease their chances of staying on PrEP. So we have to actively fight against those. I already said this is just more data sort of showing that people have high risk for HIV once they stop PrEP. So the next question I would sort of pose to them is sort of what we should do about time to protection. So say they want to start daily PrEP, how long do they have to take it before they can consider themselves protected from HIV? And then what do we say about condoms? I don't know about you all where you are, but I think here condoms are sort of going away in terms of an option for people. Not many people are opting for that, but they still can be effective. And so the way that we might counsel people about this depends on the type of sex they have and what exposures they have. So let's talk a little bit about that. So if people are taking oral daily PrEP, we do say that you should take some precaution and use condoms for at least 7 days while you're on PrEP until the medication sort of gets into your system and you have high enough levels to give you protection. And after that, if you choose not to use condoms, then that should be fine. There are differences in terms of which part of the body, like which anatomic compartment is covered. So for people who have exposures at the rectum, we think it's around 7 days. We also think it's around 7 days for the levels of the medication getting into your immune system cells, which are what sort of circulate and would be fighting off HIV if you had an exposure. And then for people, like cisgender women who have cervix and vagina, where those are the sites of exposure, we actually think it's longer. So it's around 20 days. So we should tell people, in that first week, you shouldn't necessarily expect that you're going to have 100% protection right away. It will take some time. And then we can talk to them about how they would incorporate condoms into that practice. For injectable PrEP, we think that it's around 7 days. It depends on if they take what's called an oral lead-in, meaning being on oral medication up until the time they get their injection. And then after that, we think it's around 7 days, but really the data are sort of unclear about that. But that's our best guess from the information we have. So what are some practical considerations if you're thinking about starting someone on PrEP who's sitting in front of you? I don't know what all sort of access you might have to HIV testing, what that capacity looks like, but at the very least, you want to try to get a rapid HIV test, so a finger stick blood test if you can do that. And then ideally, we would be drawing blood from people as well for kidney function, for hepatitis B testing, for syphilis screening, and then to get a lab-based HIV antigen antibody test. So that would be the best practice. But if you don't have that, a point of care test like a rapid HIV test is fine. And so the reason we want to do that is because we want to identify if somebody has HIV when they're coming in to start PrEP, because if they do have it, obviously we want to counsel them in a whole different way and get them linked to treatment. Screening for signs and symptoms of acute HIV is always important. So what that might be is fever. People might have a rash, swollen lymph nodes, or have a headache. So if they had those symptoms and there's a recent exposure within the last, 1 to 4 weeks, you might want to use a little caution and say, hey, let's wait for your tests to come back before you start taking PrEP, just because you're worried about acute HIV. And in that case, you may also, if you have access to it, want to get a viral load for HIV, because that's the best test to diagnose acute HIV. And then there is this idea for people who say, I want to start PrEP, but I'm planning on having sex tomorrow or this week, and they don't think they can wait those 7 days. There is a strategy where you can actually take 2 pills of PrEP as the first dose to kind of get your levels up quickly as sort of a loading dose and kind of jumpstart your time to protection. The same strategy that you might use when I showed you the 2-1-1 or event-driven PrEP. And if you do that, you tend to have protection within about 2 hours instead of waiting for 7 days. So some people can do that if they are really interested in getting started quickly. Okay, Any questions at all about what we have discussed so far? I thought I heard someone, but it may just be someone's microphone unmuted. Okay. No questions. All right. I'm going to keep going. So the person that we started on preps comes back for their 3-month visit for refills and labs. So this is the next big question. Is an HIV RNA or a nucleic acid amplification test, those are the same thing, what we call a viral load, is that necessary for monitoring? So let's get into a little bit about that. So this is the guideline, the algorithm that US CDC puts forth about how you do testing for HIV. So you start by sending a blood sample for HIV antigen antibody, and an RNA is what they sort of recommend. We'll talk about that last part shortly. If either of those is reactive, that person needs confirmation testing and is likely to have HIV. If they're both non-reactive, then that person we presume is HIV negative and can continue on PrEP. If one or the two of those is reactive but not the other, then we do sort of a tiebreaker with a confirmation test or a HIV viral load or RNA assay. And then depending on that is what we kind of say to diagnose either a person with HIV or without. The challenge a little bit with PrEP is that if you don't get that blood-based test initially, we know that we do miss people sometimes who actually have HIV, but then get started on PrEP. And so in the HPTN 083 study, that very first one I showed you, where they had MSM and transgender women on injectable cabotegravir, they did find that to be the case for people who were taking oral PrEP, and it happens for injectable cabotegravir too, where there were actually 3 baseline infections when people enrolled in the study. And because they were taking PrEP, they didn't diagnose the HIV. It was delayed by about 34 days. And when people were diagnosed, they already had a pretty significant viral load. And then even with people who were diagnosed in the course of follow-up for the study, the median delay was about 31 days. And then again, people had high viral load. And then the concern is that once you diagnose HIV at that point, people can have resistance mutations for HIV that could make it a little more challenging. I think the M184V, I'm not sure how much people are familiar with that, but that's a very common HIV mutation that pops up when people have taken oral PrEP or those medications in the past if they have HIV. It's actually really easy to get around. I'm not that worried about that as a mutation, but the K65R, there was only one person in the study that had that. That actually has a lot more significant implication because then you have resistance to the tenofovir component, which is a pretty common sort of element that we include in our HIV medications. And then I thought this was very interesting. There was the National Conference on Retroviruses and Opportunistic Infections, or CROI, that just happened last month. And one of the HPTN 083 researchers presented these data where they basically, in the study, they got lots of samples from people at baseline, and then they put them in a refrigerator and stored them away. And then if there was concern for acute HIV or missed injections or something like that, they would then go back and get those samples and run the tests to kind of see, okay, did they have HIV at time 0 or time 30 or 30 days or 60 days? So they kind of went back and did the testing retroactively. And what they're presenting here is basically, if you don't have access to, say, a viral load, you can still make a diagnosis when people are on PrEP using a lower cost test. So a reactive rapid test, if that's all you did and you only had one of those, the positive predictive value of making an HIV diagnosis for that is still pretty good. It's about 91%. But if you combine an antigen antibody test with a rapid test, so if that's what you have access to, your positive predictive value is about 100%. And then if one of the two of those is positive, but not the other, it drops a little bit to like 80%. So then you would want to try to get a viral load. But I think this is encouraging and sort of supports the idea that you don't necessarily always need a viral load. If all you have is a reactive rapid test and an antigen antibody, that is enough to make a diagnosis, and you can just use those two to do monitoring for people for PrEP. So what are some of the other issues that come up? I think cost is always a significant one. The problem with cabotegravir is that it's so expensive. It's about 70 times more expensive than oral PrEP, at least here in the United States, and I think in other countries as well, just based on how the manufacturer, the company that produces it, has priced it. And so that is a big deal. And I think oral PrEP itself is the cheapest option. But when we talk about monitoring, that's a sort of different side of the coin. Viral load every single time, I think, is still recommended for cabotegravir because we know that being on that injectable medication, it is so long acting that if somebody has HIV exposures and then for whatever reason they acquire HIV, it can be hard for us to diagnose it based on some of our testing. But for oral PrEP, honestly, I don't know that an RNA is necessary every 3 months. I don't do that in my own practice. The CDC guidelines in 2021 say to do that, but I think IAS USA guidelines say optional if people had exposure that was high risk in the last 4 weeks or they have acute signs of HIV. And then the WHO says the RNA is optional. And the reason that that's something we don't necessarily want to do every time is, this is sort of a back of the envelope calculation here. So if we say that the viral load costs around $164, and you're doing that, 4 to 5 times a year for a person who's getting followed up every 3 months, you can see how much money that sort of equates to be. And then it ends up being around $375,000 that you would spend on just monitoring per case of HIV that you would identify with getting a viral load. So I don't necessarily think it's worth it if you're in a public health setting or somewhere with sort of lower resources and you have a budget you need to stretch. So we're not doing it in my clinic, but just for you to know, it's something to consider. And when the CDC guidelines went out in 2021, they went back and sort of looked and see, did providers change their practice? And it seems like they did a little bit. So what you're looking at here is the light blue bars are before that guideline was put out about doing HIV viral load testing for oral PrEP, how many providers were using the viral load for testing. And then the dark blue bar is after they put it out, how many did. So you can see that in terms of any viral load being drawn, it went from about 12% to 39%, but I don't think that's really a significant sort of increase in my mind. Still less than half of providers are doing this, and I think it's because of cost. Oftentimes insurance companies sort of balk and don't want to pay for it, and then the patient ends up having to front the cost, which is not fair, I don't think. Okay, so changing gears a little bit. So the same patient that we've been thinking about comes in for their 6-month refills, and they tell you that they are thinking about starting feminizing hormones. They have felt like they are transgender for a while and wanted to talk to you about this. So the reason this is important because there are a lot of questions that come up about whether PrEP will affect hormone therapy or not. So I wanted to talk about that just a little bit. So there have been a lot of studies done. So in this study, this was looking at transgender women and transgender men who were receiving directly observed therapy with PrEP, and then they got dried blood spots for tenofovir levels. And you can see that across the different groups, transgender men, cisgender women, and cisgender men, the levels of the active version of PrEP in the body were not that different. So people who were on gender-affirming hormones, it didn't seem to affect the levels when they were using oral FTDF or Truvada. So I think that's encouraging. We can tell people that we don't think that that will affect their hormones. So either way. And then this is again looking at people who were transgender at 12 weeks, tenofovir levels in people who were taking hormones and then people who weren't. And again, I think the take-home message here is that for estradiol, people who are on estrogens, it didn't really seem to be affected by it. People who are taking testosterone, it was marginally lower when they were on oral FTDF, but the change didn't really seem to be clinically meaningful. So I think my sort of summary of this is that it is fine. You can reassure people that there's not a big issue. And again, at this meeting last month in Croy, The same idea was sort of evaluated. They didn't find any significant interactions. And this time they were looking at FTAF, or the Descovy version of PrEP, with or without hormones. It seemed like the concentrations in the blood and inside the cells, and then also at the rectum, were comparable. So I think that's encouraging, and you can reassure people that that is fine. So now the patient says, I'm in a new relationship. They want to give PrEP a bit of a break. They've been doing it for a while, and they don't feel like it's necessary now because they're going to be in a monogamous relationship, which I think is valid. So their question is, how long should I continue taking PrEP after I had my last sexual exposure? So this is just a schematic to kind of show you, what a person may be doing around their sexual exposure and the HIV prevention medicines that they're using. So if people have a single exposure, we give them PEP for 28 days after. So that's depicted on the top row. In the middle, somebody who's having sort of frequent ongoing exposure should be taking daily PrEP, because you want them to have a continual amount of medication in their system. And then for people who are having occasional exposures, it's okay to do that sort of 2-1-1 or intermittent or on-demand dosing, where they just take the PrEP around the time of sex. How can people kind of safely stop PrEP? So they decide they don't want to do it anymore. What do we tell them? For oral PrEP, the WHO basically says they should take 1 dose a day for 2 days after the last exposure if they're a person who is male, assigned sex at birth. For people assigned female sex at birth, they should take 1 dose a day for 7 days after their last exposure to kind of cover the last little bit of potential exposure that they had. CDC says a little bit different. They say protection will wane in about 7 to 10 days after daily use. And so you want to counsel people accordingly. And then if they have hepatitis B, let them know that, they could have a flare if they stopped the medication. It is important to document the HIV status at the time of discontinuation, just so if they come back in later and you get a repeat test, that you will have something to compare to. And then for injectable PrEP, it is a lot more complicated, and we can talk about it if people want. But if people say they don't want to do it anymore and they just don't come in for their next injection, the recommendation actually is to transition them to oral PrEP, because there is concern that when the medication is, I'll show you this graph here, how long the medication stays in people's systems. So this is weeks on the bottom axis here, and then on the top is the level of the cabotegravir in the body, and it does differ between men and women. But you can see that after a single injection, basically, the levels will still stay in your system for a year or longer. And so we're concerned that if people just get the 1 injection and never come back, or they decide they don't want to do it again, at some point those levels will go down lower enough that you won't have a therapeutic benefit, or it won't be enough to prevent HIV, and then resistance can happen. So that's a major concern. And so the reason why you tell people to be on oral PrEP. Okay. Person comes back and says, okay, actually, I want to try to do on-demand PrEP. But then you couldn't reach them when you did some outreach for the next 6 months, and then they give you a call and say, hey, I want to refill my PrEP. This happens, I think, all the time, where we're sort of going back and forth. We don't hear from people for a while, and all of a sudden they say they want to start PrEP again. So I think this brings up the idea of sort of structural interventions we can do to increase PrEP engagement and persistence. Some of these we've already kind of talked about. I will skip over this just for now. Happy to come back to this if people have more specific questions about it. There are a lot of strategies that have been studied and can be useful to help keep people engaged in PrEP care. Okay, so let's shift a little bit now, saying fast forward a couple months later, they come in and say they ran out of PrEP 2 months ago, but they did have condomless sex last night with a partner who has HIV but is not taking antiretroviral medication. So this is a situation where you would consider somebody to do post-exposure prophylaxis, or PEP. And so let's talk a little bit about those options. So post-exposure prophylaxis, in contrast to PrEP, which we've been talking about all this time, is when people start antiretroviral therapy within 24 to 72 hours after an exposure where they didn't have any sort of coverage. And that is to prevent them acquiring HIV after an exposure. So these are the regimens that are recommended. So dolutegravir with tenofovir and emtricitabine, or you can use raltegravir. And then alternative regimens include a boosted PI, darunavir and ritonavir with those. And then people who have low creatinine clearance, there are other options that we honestly never use because AZT or zidovudine is very toxic and nobody wants to use that anymore. So almost everyone will use one of those two preferred regimens. But there are a lot of barriers, I think, that come up with PEP and a reason why it's underutilized. So there are providers who are uncomfortable with this. It can be expensive and if you don't have coverage for it. Again, the stigma piece comes in where you have to go in and tell a provider I had this exposure, and it can be really embarrassing for people. And there's limited access to a provider within that time frame. So like if somebody has an exposure Friday night, the clinic that they go to is probably not going to be open on the weekends. And so who do they go to get the PEP? If it's after hours, that's a big consideration. It is a medication that we give for 28 days. So that can be a long time for people, especially if they're having side effects and they're not used to taking medicines every day. And then the pill burden can be part of it as well. So if people are taking raltegravir and oral FTDF, that is 3 pills a day for people who may not be used to that. So they may have trouble adhering to it. So there has been some new data coming out looking at 1 pill a day using bictegravir, emtricitabine, and tenofovir alafenamide, which is known as Biktarvy, which we use primarily for HIV treatment. But there is now growing evidence that it's safe to use as PEP. So instead of using those 3 pills or 2 pills, we can give people 1 single tablet that is really well tolerated. Adherence seems to be high in these studies. Few people discontinue due to side effects. And so I think that is an option. But again, cost is always a consideration as well as access to the medication. And then there's this idea as well about PEP in pocket, which is essentially giving people a prescription in advance for something like the Biktarvy or FTDF and dolutegravir that they can just have on hand in case they have an exposure. So this is it for somebody who says that they don't want to take PrEP every day, but they may have an exposure they're worried about. This is something that people may be interested in doing. I think that's a little controversial. Not everyone likes the idea of giving someone a full bottle of a really costly HIV medication to use as PEP, but it has been done in places like Canada. And this was from a poster that was presented at CROI last year. And then there was a really interesting study that was discussed last year at CROI, and then they gave an update this year that was done in southwestern Uganda and then western Kenya, where they gave people the option. They said, we have a lot of recommendations and choices that we could give you, but what do you want to do? So all the things we've talked about, do you want to do injections? Do you want to do oral medications? Do you want to do PEP in pocket, excuse me? And then people made their own decisions. So you can see here when people had the idea, the option for dynamic choice where they could choose what they wanted, and sometimes that sort of switched back and forth. The uptake of HIV prevention and coverage was a lot higher. So overall, 65% in the people who had choice versus 26% in the people who just were given sort of standard of care. So I think that speaks a lot to the fact that people do want options, and we should be willing to be flexible and work with them on that. And then one last thing I'll just talk about for PEP before we sort of go into a lightning round of sort of what's coming in terms of new interventions. There is some interesting thought and sort of data that's circulating about whether or not we actually need those 3 drugs that are in Biktarvy or in dolutegravir plus oral FTDF for PEP. So it is a lot of medications, and one of those, the integrase inhibitor, is a medication we want to kind of keep precious because it is a backbone for a lot of our HIV treatment. So there are people who are looking at whether or not we could just give the same pill that people would take for PrEP as post-exposure prophylaxis. And the rationale for that is basically in one of the French studies that was done looking at PEP, they gave people a dose of FTDF, and then they looked at levels in the blood and the rectum, and then also in the genital tract. And they could see that, levels remained very high, even out to, 100+ hours. And so, if people gave a double dose, that would even be higher. And maybe that's long enough to keep the level of drug in the system above the target that you want for protection for a week or 12 days. And so maybe taking that alone could be sufficient for PEP. I'm not necessarily recommending that now, but I think that's really interesting and then something to think about in the years to come. We might hear more about that. I've heard murmurings about whether the PEP guidelines will change, but we'll see. Okay, so in the last sort of section here, I just want to share with you sort of what's coming for PrEP and PEP. A lot of really exciting sort of innovations that might be of interest to you. So currently, this is our toolkit that we have. A lot of the things we've already talked about. So oral PrEP. I didn't talk much about the dapivirine ring again, but that is an option that WHO has endorsed for cisgender women. And then injectable cabotegravir is another option that is the most recent that was approved in 2021. But honestly, there are a lot of options that you can see here that have been studied. Some didn't really come to market, but a lot of really interesting delivery systems. So things like diaphragms, enemas, implants that can be put into the arm, patches that can be put onto the body, a vaginal film or vaginal gel. So there's a lot of ways that we could deliver prevention medications. And some of them can even be combined with other products. So like an implant that might have oral contraception in it or not oral, but contraceptive medications like, progesterones or things like that with a PrEP medication. So that has been studied and looked at. So, it's kind of an exciting time and hopefully we will see some of these products come to market. But I just wanted to show you a few examples of these. So this is a ultra long acting implant that has cabotegravir in it that can be put underneath the skin. And once that happens, it sort of develops into this hardened solvent that will leach out drug in the body for a year or more. So you can see in this picture here, it was put into mice, into their arms, and this sort of white blob that you see here on X-ray, you can kind of see over time how long it stayed in the system, and then the levels of the medication stayed up for many, many days. And then when they remove the implant, you can see the medication levels drop significantly, suggesting that it really was the implant that was keeping these levels high. So that is one thing that's being studied. We'll see more whether or not it will come to market. Another option is instead of taking oral medications for PEP or for PrEP, you could do a rectal insert or a vaginal insert. So this was studied in non-human primates where they challenged them with the primate version of HIV and found that it did protect them against HIV exposure. So this might be another option when people don't necessarily want to take pills, but if they had an exposure they're worried about, they could just put in an insert like a suppository basically, and that would be sufficient for PEP. So that would be, I think, really convenient for people. And these are the data that were shown from the animal studies. So essentially, if the insert was sort of put in within 4 hours of the exposure, 100% of the animals were protected. If it was within 8 hours, 94%, and then a day later, it was around 77%, which is a little lower, but I think still reasonable. Versus placebo, when they didn't get any of the insert put in, then 100% of the animals got the viral infection. So seems like it works. So stay tuned on that. And then this one actually is being studied right now and is planned to come to global market next year, according to the manufacturer. So this is lenacapavir. So basically, it's being studied right now in the Purpose 1 and 2 trials. And then soon they're going to start Purpose 3 and 4. And these are all being done in different populations. And they're looking at this long-acting agent for PrEP, which basically could be sort of put under the skin every 6 months. And I think that would be a lot more favorable for people than getting an injection once or every 2 months. And then lastly, there are some implants that are interesting that could be sort of put under the skin and the arm, and then again, put out medication slowly over time. And then there are also these refillable ports that can also be placed under the skin. So if a person decides they don't want it anymore, it can be removed, or you can just use a syringe and pull out all of the medication. Or you can even refill it that way. So yeah, stay tuned. I think that's super interesting to see that we could have more options for people as time goes on. So covered a lot of information. These are my conclusions. You know, we still think PrEP uptake is not great, especially for people who have the highest incidence. So it's our jobs to sort of make sure we can get the product to people that need it. There are a lot of options for prevention, whether that's daily, oral medication, or around the time of sex, or injectables, and then more things coming, as you saw. We should work with people to improve adherence as much as we can, but PrEP persistence still remains a challenge. And I think people still go on and off PrEP, and they just have to be aware that their risk for HIV can persist when they do that. PEP in Pocket is something coming and maybe an interesting addition to our prevention toolkit, as well as all of the other things that we discussed. The last thing I wanted to leave you with is that there is a new national HIV PrEP curriculum that is created and hosted here at the University of Washington. It's completely free. It's open to anyone around the world. You just need internet access to go on. You can log on and do modules that will take you sort of step by step through what to do for PrEP. They have some advanced modules as well that will take you through certain scenarios. So please check that out. There are graphics and information cards and brochures and things that you can print out and keep in your clinics and give to patients as well. And these are just some resources that I mentioned in the talk, and ones that could be of use to you if you would like, especially this clinical consultation line. If you have a particular question about PrEP, you can call and talk to someone directly about your concern, and they can help you out on the spot. So that is all I have, and I promised I would try to leave like at least 8 minutes, and I think I did it.
Thank you, Dr. Callahan. Yes, you did it perfectly. Stop for a dime. Thank you so much for that absorbing and really interesting and thought-provoking session. So you have a slightly full house, so I don't want to hog the questions, even though I have some. So I'll leave it to anyone who has any questions for Dr. Callahan. You can either unmute and ask a question or put your question in the chat box.
Don't be shy. I love questions.
There's a question there from Rickson. He says, earlier in the presentation, you mentioned that FDA withdrew the Praveen vaginal ring for consideration, and he's asking why that was.
Yeah, that's a good question. I think some of it was a little hush-hush, and I don't know all the details, but I think that the manufacturer, basically, who would submit the application to the FDA, sort of got wind of the fact that I think the people who make those decisions about what is approved and what's not, they were unlikely to give it approval in the US because the data they didn't think were as strong as they maybe would have wanted. And so the manufacturer just chose to remove their application and not move forward with it because they didn't think it was likely going to get approval in the US. So a lot of that is sort of bureaucratic, and there's a lot of stuff behind the scenes that I don't necessarily know, but it is available in other countries, and a lot of research around preferences for that option in women compared to oral PrEP or injectable.
Okay.
And I had a question as well. You said you said it was harder to diagnose HIV if someone had been on injectable PrEP. I wonder if you could speak a little bit more about that.
Sure, yeah. So all of these medications we use in one way or another for even HIV treatment as well. And so their effect is that they decrease the production of HIV in the body for someone who has HIV. So they suppress the production of antibodies and also suppress the production of antigen of HIV. And so those are the things that we use to make diagnosis. And so if someone has an HIV infection or they acquired it, being on those medications like cabotegravir could suppress production to the point where we actually aren't able to detect it in a standard way. So you might test someone at month 0 and then everything was negative, and then they test them again at month 1 and only one of the tests was positive, or it was like a faint positive, and then you repeat it again a couple months later and it looks completely different. So the test can be all over the place, and it makes it really challenging to diagnose HIV specifically with cabotegravir. So I think that is why it is recommended to get a viral load because you may send all of those tests off, and the only thing that is positive is the viral load is positive at a low level. And then that should still say that a person has HIV. So you're trying to get as much information as you can to make the diagnosis.
Hello.
Yes.
Yes. Thank you so much for the presentation. That was very, very good. So I'm from Haiti. We have a lot of problems with PrEP in Haiti, especially for the adherence. So I don't know if the problem is like counseling. So I'd like to get some information exactly about adherence, because you said in US that is okay. So I'd like to know what strategies exactly that you employ to improve that. Thank you so much.
Yeah, sure.
Yeah,
I
thanks.
can, let me stop sharing and go back to that slide I had on it.
Yeah, thank you so much. All right. All
right. Let's see here. Here we go. Okay. This was so one of the slides that we sort of talked about. This is just a list, it's not a complete list, but I think these are some things that we have seen from the literature that can be helpful for adherence for people. So having a clinic or a person to send, reminders, like a text message reminder, SMS, or email, or phone call, whatever the person's preferred method is. Pill boxes can be helpful for people, or giving them, like a keychain that may be discreet and has a different shape than looks like a typical pill box. So in some studies, they've given, women like a lipstick container that they can put their pills in, or peer-based PrEP navigation and adherence support is another option. So those are things I think from the literature that have been shown to be helpful. But honestly, I think it really depends on the context where you live and who the patients are. And I think you have to talk to every person individually and sort of find out what is their life like, how are they taking their PrEP, what do they think about it, because that is the way that you can kind of creatively come up with solutions. But I think these are just generally some that could work for people. But yeah, it is certainly a challenge everywhere in the world.
Okay, thank you so much for sharing. So, our context is sometimes very difficult, but I'm going to try exactly what I'm going to do. Thank you so much.
Yeah.
All right.
I see another question there in the chat. It comes from Gracie. He says he's not sure if he missed it, but will demand PrEP, can you explain if it's still an option for persons and if there are any complications or risks? Because he recognizes that a lot of people don't want to take pills every day, and so the demand would be better for them.
Yeah, let me go back to this slide. Sorry. Guard your eyes if you, I don't want to make people nauseous. So yeah, these are the options basically for who it's recommended for 211 or on-demand dosing. So basically, we don't really have great data for cisgender women, trans men, so people basically with a vagina. If they're having vaginal sex or exposed at that site, we don't have great data that 211 works for that population. It's being studied right now, but we don't have those data right now. And then for transgender women and cisgender men, we do have a lot more data. So those are the two populations right now that I would recommend 211 or talk to them about. And then specifically, again, it's only for FTDF or Truvada because it hasn't been studied in FTAF or Descovy. There's not really a good, there's not a reason I don't think it would work, but that's just based on the evidence, and that's how guidelines are created. So it is for cisgender and trans men who are having sex of any kind and with FTDF only.
Thank you so much. And I just want to remind all of our participants this evening that the slides will be shared both via email and in our WhatsApp group. And we'll have the edited recorded session for sharing immediately after, once the edit is done rather, you'll get the slides immediately and you'll get the edited recording a couple of days after. So that'll be ready for you by Monday. Let me pass it back to Greg, unless there are any other questions.
Actually, I just wanted to ask something very briefly because to Dr. Chase, Dr. Boyce here. So one of the issues that keeps popping up still is that some agencies are reluctant to initiate PrEP programs because of concern regarding increased risk of STIs, or increased rates of STIs, whether the data supports that or not. Can you just speak briefly to that? Because I think that's one of the issues that we are having some difficulty convincing some of our voices here about.
Yeah, and I didn't put that in here. Maybe I should have. You know, that idea is called risk compensation. So basically, providers are worried that if we offer someone this sexual health intervention like PrEP or doxycycline PEP, that's going to give or tell the patient that they have license to like go wild and start having a lot more sex and not using condoms ever, and that's going to make STIs worse. That's been a discussion and a concern that people have had for over a decade now, and it hasn't really borne out in the literature. So when this has been looked at in like meta-analyses across many countries, it doesn't seem to be the case. So I think we can kind of put that to bed, that people who are started on PrEP don't necessarily have sort of a higher risk for STIs. Honestly, a lot of people who aren't using condoms have chosen to do that even before they start on PrEP. So the fact that they start on PrEP isn't necessarily going to change that fact. For some people it does, but not everyone. In the clinic settings where we have seen an increase in STIs among people who get started on PrEP, what we see is that it's not for everybody. It's just a select proportion of people. So a certain subset of people who already had a lot of STIs are the same people who are going to already have a lot of STIs, but it's not everybody. So I think that is not a big enough concern to me that I would not offer someone PrEP, because getting HIV is a really significant thing in life in terms of your health and lifelong sort of needing for medication, morbidity, mortality, all of that. And I think that trumps to me any risk of getting chlamydia once per year, you know, more than you did before. I think that's pretty trivial. The risk benefit is a lot, you know, clear for me, but.
Thank you, Dr. Campbell. I think it's one of the frustrations we sort of have when we don't have a PrEP program, where you see all the data and just wondering, so what's the argument you need to make to get the program going? So again, thank you so much for your time and the effort, and thanks for a wonderful presentation, and thanks everyone for coming out on a slightly gloomy Friday afternoon, but it's all right. It's still pretty nice. So again, so that's it from us at Mrftt HIV STI Echo. We shall see you again in 4 weeks' time. Have a safe weekend and take care, everyone. Bye-bye.
Thanks.
Thanks.